Thank you very much. Now, to my fellow speaker, Jenny, I don't know whether you're still here, but I know you'll be surprised, but I was actually around in the 1990s and playing in case mix, and I can tell you that by the looks of some of you in the audience, the parties in South Australia haven't changed. But that was why case mix was extraordinarily exciting back then. So I want to talk to you about the development of a national set of high priority complications. And I guess one of the problems is healthcare is a bit like this. It's all down and dirty. And if you just look at the score or the scoreboard, you don't actually know what's happening in there. And that's the story of health. And a lot of what we're basing our systems on is the scoreboard, and we don't actually know what's truly happening. So to try and understand what's truly happening, a joint working party between IHPA and the Australian Commission for Safety and Quality in Healthcare was set up, and that working party was to try and explore whether administrative data could inform clinicians of anything, particularly about their practice, whether it could be used for peer review, and whether it could be used to benchmark their practice against others. And then secondarily, to explore options to incorporate elements of safety and quality into hospital pricing. There was an advisory panel that had jurisdictional experts, it had clinicians, it had consumers, it had health managers, health economists, and even me. And I guess the two things that were unstated but are basic premises: activity-based funding probably already drives quality and safety. It certainly drives down length of stay. It drives more efficient models of care, and if you consider that a measure of quality, then I guess it's doing something about quality. There are lots of efforts to minimise complications because complications cost you more money and therefore might be a loss leader. And certainly in most of the states, it's led to networking of tertiary services and better targeting services to patients and matching the intensity of the service to the needs of the patient. So there are two other additional possibilities for to drive quality and safety in an activity-based funding model, and they are the use of administrative data to feed back to clinicians and to benchmark for clinicians, and the second is to use pricing to drive safety and quality. And I'm going to briefly speak about both of those. Oops. So the Joint Working Party took a whole series of streams of work. First of all, it did a literature review on integrating safety and quality in hospital pricing systems, and I'll briefly speak about that. Then it did an analysis of hospital-acquired diagnoses to see what their effect was, both on the DRG and on complexity and resource use. It then used coded hospital data and administrative data for reviewing, reporting safety and quality, and looked at how that might be fed back to clinicians. It analysed clinically relevant hospital-acquired complications that were routinely derived, and then set up two subcommittees. One, a proof of concept to evaluate the reproducibility of administrative data and its utility when fed to clinicians, and secondary, a best practice pricing evaluation. Now, this is some work done for the Joint Working Party by the University of Wollongong. It was a literature review looking at pricing and funding incentives to improve quality. As you can see, the evidence was equivocal in this literature review, that it was equivocal whether pricing could drive quality. There are, however, some domestic applications in the states and territories in Australia. The review believed that quality data, there was good evidence that clinical audit and registries would drive improvements in quality, and that at this stage there wasn't good evidence that administrative data would drive improvements in quality, and that if you were going to bring in a pricing model so that you altered the case mix or the activity-based funding to pay for quality, that you needed to decide who you were targeting. Is the person you're targeting the hospital? Is the person you're targeting the surgeon or the doctor? Or is it the team? Or is it in fact the patient? Should we be giving the patient extra money to spend on achieving quality? So the Joint Working Party started to explore administrative data, and set up three projects. One was an analysis of hospital-acquired diagnoses and their effect on case complexity and resource use, an environmental scan of how administrative hospital data has been used to drive quality improvement, and then to develop an Australian national set of high priority hospital complications. So HPA were asked to look at hospital-acquired diagnoses on case complexity. They looked at the national data sets, discovered that 10% of all episodes of care had a hospital-acquired complication, a hospital-acquired diagnosis, that hospital-acquired diagnosis in fact only changed the DRG in 3.1% of cases. So even though you might have a hospital-acquired diagnosis, it doesn't change, or doesn't frequently change your underlying DRG. That patients with those hospital-acquired diagnoses were much more expensive, with an average of $9,000 more expensive per episode of care, and that was essentially because their length of stay went up. And in fact, if you wiped out all the episodes of hospital-acquired diagnoses and could prevent them, you'd save between 11 and 16% of inpatient hospital expenditure. So they're pretty extraordinarily expensive and fairly important. We then did an environmental scan, which the National Case Mix and Classification Centre did for us, looking at whether we could use administrative data to drive safety. One of the issues they felt was that while primary diagnosis was fairly robust in our system, secondary diagnosis may be less robust, and that there was no real data about validity or accuracy or reliability of secondary diagnoses within our notes, that they could be used as a screening tool to flag possible areas of concern or to feed back to clinicians, but they shouldn't be the only way you measure quality and safety in the system. And then lastly, KPMG did some work for us to try and develop a list of clinically relevant high priority complications. And we came up with 39 complications in 15 complication groups, and I'm just going to give you a taste of that now. So clearly pressure injuries is an important complication from a hospital stay. Similarly, falls, hospital-acquired infections, and so on. So a combination of clinicians and KPMG worked down this list to come up with what we thought were plausible, potentially avoidable, high-priority hospital complications. And so on. Interestingly, there's delirium there, and since I've come to the commission, 60% of people in ICU are delirious, and that's just when you look at the staff. And you know, in my 20-odd years as an ICU doctor, I never once wrote delirium in the notes. Okay, all my patients are delirious, but we never recorded it. So it's a testament to the problems of the area. So to look at a couple of these complications, for instance, venous thromboembolism, when you look at the data, this is in 2 states, 2010 to 2012, 16,000 patients had a pulmonary embolus. Those patients had excess patient stays of almost 19,000 days and an excess number of days in hospital per complication of 11 days. So you can see that if you could wipe out pulmonary embolism, which in theory you should be able to wipe out a lot of it, you could actually decrease the burden of disease on these 16,000 patients. You could decrease the excess days in hospital and decrease the cost to the system just by doing something that intuitively is good care for a patient. Looking at venous thromboembolism another way, these are teaching hospitals, essentially A1 hospitals out to rural and remote hospitals, and you look at the variation in the rate of reported venous thromboembolism. So in a teaching hospital, from 3.2 per 10,000 patient days right down to almost none. So either this hospital at 3.2 is a real outlier, or some of the others are completely underreporting their rates of VTE. So a lot of scatter there. Similarly, a topic that's costing even more bed days, hospital-acquired infections. If you just look at 2 of those, urinary tract infection, 162,000 excess bed days in 2 states over 2 years. Heck of a lot of excess bed days. And similarly, bloodstream infection or pneumonia, both over 100,000 bed days, and close to 10,000 patients in each of those groups who were suffering from a hospital-acquired infection that's potentially preventable and costing the community and the patient a heck of a lot. So with that as a background, what do we do now? As clinicians, there are a couple of things that intuitively we would think were bad signs in a hospital. One was unplanned return to operating theatre, and another one was admission to an ICU that was unplanned, and the third one would be having to have a MET call on you. Now, in fact, none of those data items are in our national data set, so the first thing we did was set about revising the national data set to put in extra data items, and then we wanted to develop a proof of concept study to look at if we fed this data back to clinicians, whether it actually made any difference. So the proof of concept study is currently undertaken in 4 hospitals. It hasn't completed yet. It's due to finish at the end of June, and it's assessed the accuracy and completeness of the complication set derived from routinely collected hospital data. There's a hospital in South Australia, Victoria, New South Wales and Queensland contributing data to this, and we then want to feed that data back to the clinicians to see if they find it at all useful. The first hospital that's done the feedback of data here in South Australia has found that the surgeons thought the data was completely irrelevant, which would be pretty typical of surgeons, and the physicians liked it. So we'll wait and see what happens when the other hospitals get their data together. As I said, we've developed some new data elements around unplanned return to operating theatre, around unplanned admission to ICU and rapid response teams, and they were signed off yesterday and should be on the Australian Institute of Health and Welfare's metadata online registry as of tomorrow or this week. And so hopefully hospitals that wish to collect those data items will be able to start doing that soon. And then the third thing is we wanted to develop some clinical documentation guidelines. Now, as a junior doctor, if you go on my ward round, when I'm doing a ward round, I'll go to a patient and say, oh dear, Mr. Jones has had a fever last night, and look at that, his white cell count's gone up to 20, and he's got some right upper quadrant pain, and he had a splenectomy last week, and so he's had a laparotomy. Maybe we'd better do a CT scan to see whether he's got a subphrenic abscess. Okay, that's what the ward round would say. What the notes will say is CT scan. Okay, none of the cognitive stuff goes into the notes, unfortunately. And what we need to do is, especially junior doctors, is teach junior doctors how to write more information and more cognitive information, information about why decisions were made, information about why diagnoses were made, rather than just process-based information about what the boss wants done this afternoon. Okay. So the second phase of our inquiries was to see whether, in fact, we could bring in a pricing model that might drive quality and safety. And there are 4 ways the literature describes this being done. One is best practice pricing, where you establish whatever best practice is, and then you apply a price to the provision of that practice. Okay? An alternate method would be normative pricing, where you use price to influence the delivery of care. So, for instance, you might decide that you want lots of day-only surgery, so you increase the pricing of day-only surgery and decrease inpatient surgery. You might have a quality pricing structure models where you link accreditation to funding, or you might have a payment for performance where you link quality, safety and funding through the imposition of incentives or disincentives to certain behaviours. So when you look at the literature around best practice pricing, the place that's done most best practice pricing is in the UK, and what they tend to do is give you a bonus if you deliver a bundle of care. And a typical one is the NHS fragility hip fracture clinical care, where if you deliver those 8 clinical standards, you get an extra $1,000, £365. That in the UK is driving best practice care for fragile hips, and the main thing it is driving is early surgery and an orthogeriatric model of care so that elderly people aren't left to the orthopaedic surgeon, that the geriatrician helps look after them. Normative pricing is also something that's been tried in the UK, and it's an attempt to allow price to drive the model of care by creating incentives for the desired model. And so there's a thing called the British Association of Day Surgery, and they have this normative pricing for breast surgery, hernia repair, female incontinence, minor orthopaedic surgery and urology. And what in fact it does, it selectively gives you a higher price to do the same procedure as a day-only procedure than if you did it in the hospital as an overnight procedure. So you get rewarded, again about £300, to do the thing in a day-only setting. Quality structures pricing, again, is a similar idea where you link the pricing to quality and safety, particularly accreditation. It's been implemented in the US mainly, and there's good evidence that quality activity improves clinical practice, but there's little evidence that the quality activity is linked to the pricing, so that it may not be the pricing that drives the improvement. And the last way you might price quality is to do a quality structured pricing. Whoops. Where you, last one's payment for performance, where you actually pay people to perform well. Now, in a typical US manner, this has been done in this US Premier Hospitals quality incentive demonstration, and they chose a series of diseases: myocardial infarct, heart failure, coronary artery bypass grafts, and so on. And what they did was set up a competition between the hospitals. And the hospitals that did best at those diseases in the competition, if you were in the top 10%, you got an extra 2% of all your activity-based funding for those conditions. If you're if you were in 11 to 20% of the best hospitals, you got an extra 1%. And if you're in the top 50%, the Medicare in the US announced that you were doing well. And later on, they changed it so that after the competition, if you were in the bottom 10%, you lost money in a typical US competitive arrangement. So that's pricing for performance. Now in Australia, there are two initiatives similar to that. One is in Western Australia, where there's a hip fracture premium payment. So you get a bonus $200 for the hospital if the patient's operated in a timely manner and if they have an orthogeriatric model of care. So 6 clinical indicators have to be met. And in Queensland, they've reduced payment by 20% for a fractured hip if you don't have surgery within 48 hours. Again, trying to drive practice by altering the funding. Now, most of us would believe that $200 to the hospital or 20% loss to the hospital would actually drive the hospital administrators to think about whether or not they wanted to improve the turnover of fractured hip patients. And in fact, that's what seems to be happening. Fractured hip patients are given precedence over some other urgent or semi-urgent patients. So if you were going to introduce a costing model, one of the key considerations is a financial incentive actually appropriate? Can you get the clinical outcome and will that improve patient outcomes? Can you get rid of the undesirable clinical behaviour without an intervention? And then who you target. As I said before, do you target the doctor? Do you target the whole team? Do you target the administrators? Do you target the hospital? Or do you target the patients? And so we formed a subcommittee that looked at best practice pricing for clinical quality improvement in Australia. Because there's a national guideline for the care of fractured hip in Australia, and because there's about to be a clinical care standard for fractured hip, we decided to base the model on that. And the model at the moment is being evaluated to see whether, in fact, if you perform some of the elements of those best practice guidelines, you would get a bonus payment. But obviously the elephant in the room, we don't know yet whether any of this stuff is actually going to make a difference. And that's actually what we're all here to do, is to make a difference. Now, I wanted to just, as I'm finishing, show you a few little slides that would suggest to me that the world hasn't changed all that much as certainly in intensive care, I think. This is patients being looked after in the 1918 Influenza Pandemic. Okay? And there we are in the 1950s in the polio pandemic, with lots of cuirass ventilators, iron lungs. And similarly, this is last year in the Ebola pandemic. And I put it to you, even though our systems are a heap better, things actually haven't changed all that much. Thank you.